Hello?
Can you guys hear me? Could you please raise your hand if you can hear me? All right, thank you, Janelle. Thank you guys for raising your hand. For some reason, I could not get my headset to work. So I was starting to panic. I've been sitting here for a while trying to get it all working. But anyway, all right, I'm gonna lower your guys' hands here. All right, and then there we go. All right, so now let's get started. All right, my name is Debbie Hill-Basell. Tonight we're going to be doing case list review. Some of you have already turned in your case list, which is great, and those of you who haven't, we'll still be able to go over some items and you'll hopefully be able to get a lot out of this. So let's take a look at how you participate today. So what you guys can see is you have a little orange arrow up in the top right hand screen. What that arrow does is it basically opens and closes your panel. So for some reason, if you couldn't see what you needed to see, you just click on the arrow and that will move that. Looks like everybody is on mic and speaker, so you don't have to worry about how to use a telephone. There's nothing specific that you need to do, but if for some reason you got disconnected and you still wanted to be able to listen or participate, you can click the use telephone, and what it will do is it'll actually give you a phone number, an access code, and a PIN number, and you can join the conference. The other thing is with regards to volunteering, you just raise your hand. Also feel free to raise your hand if you have any questions, etc., and I will get to you. The one thing that I can see right now is every single one of you are muted. It looks like maybe, yep, you're also muted on your end as well as muted by me. Don't worry about that, but when I call on you, if I say to you, you're muted on your end, look up underneath your little orange arrow. There's a circle with a microphone in it. Make sure that is green, and then I'll be able to hear you. All right, so that's the main thing today. So what I want to do is we're going to actually just start with who would like to volunteer. I know, Richie, your case list is there, and Aviv, yours might be too. But so, Richie, don't you want to volunteer? Because I want to go ahead and let me get out of here and take this down and get to the case list. Yeah, that's right. So Aviv and Richie, you both have case lists here. So who wants to go first? One of you has to go. I'll be super nice. We'll just walk through it. Okay. All right. Thank you, Aviv. All right. So I've unmuted you. You're muted on your end. Can you unmute your microphone? There you go.
Hi, can you hear me?
I can hear you just fine. Hey, thanks for volunteering. All right, so before we even get started, you guys, just look at tonight as we're just going to walk through this together. I don't want anyone to be nervous. I don't want anyone to be thinking that this is not going to be a tough session like where I'm going to just grill away at you. This is going to be let's all get our feet wet. Realize everybody else online, we're all cheering for each other, right? Because what here's the issue with the oral boards. You guys are super smart or you wouldn't be here to begin with. You're even more super smart because I think you must all have a little OCD, which is why you've even signed up for Exam Pro, and you're pushing yourself to, you know how important this is. You just want to do it once, get it done, etc. Well, with regards to the oral boards, if this was a written test, you know how to study for a written test. You've done it all your life. You know how to be an excellent OBGYN. What you don't know how to be and where you don't have good confidence is how to be a good oral test taker. And so that's what this is all about, is how can we just help you walk through that? So with that in mind, let's go ahead. Do you have a particular case list you would like to start with? Or The other thing is sometimes the candidates will say, you know what, I've got a case that's really bothering me. Would you just help me walk through it
Um,
and how would I explain X, Y, or Z? So if you have one of those cases, we can do that also.
Nothing come to my mind right now, so I guess we can do it randomly or however you want
Okay,
to do
let's just do this. Let's just pick, go to your OB case, and then
it.
I'm just gonna pick out something and I'll just ask you some questions. All
Sure.
right, so let's see here. All right, let's do just patient number 4. So you have a 26-year-old G7P0. Why is she a 7-0? Is she recurrent pregnancy loss? Why is she a 7-0?
So for this patient, she had it was mixed. She had three. She had miscarriages and she had elective terminations.
Okay,
So
so with regards to, let's say they asked you, well, how would you evaluate someone for early, like recurrent pregnancy loss? What's the actual definition of that, and when can you start a workup?
we're looking at number of, if we're looking at early and first trimester, we're
Mm-hmm.
looking for at least two or more of pregnancy loss. Or if we're looking at later on second trimester, or I think it's about 10 weeks, then one or more, then we can do a workup, which will include,
Are
um,
you there? Yeah, okay.
yeah, can you hear me?
Yeah, I can hear you. For some reason, you just went out for a second, but I can hear you
Oh,
fine now.
sorry. And if it's a later on pregnancy loss, then we can do the workup even after one or more.
Okay.
The conditions got, it used to be two or more and three or more, but then it got softened because patients were worried and people didn't want to wait until the next one. So people start doing it earlier now.
Okay, so yeah, so if they asked you, the part of the reason I bring this up is you probably thought I was just going to ask about preterm labor, P-prom, etc. And I am going to get to there, but it's always good to really look at your case list and see what else is kind of different about this case list. And the fact that she was a G7P0, my first thought was, oh my gosh, has this poor patient had recurrent pregnancy loss and she's had 7 first trimester losses? If yes, my next question would be, how do you define it? And you're absolutely right. It's always in the past been defined as 3 first trimester losses, but we can start the workup after 2. And you are right, they have softened that somewhat because two first trimester losses in a row is very distressing to anyone, and it's reasonable to start an evaluation. If I asked you, what would you, if what are the different causes for first trimester recurrent pregnancy loss, tell me what those are and how you would evaluate those.
So it depends at which time are we looking at. If we're looking with someone that is having right now um, miscarriage or an abortion, and we're looking at incomplete, missed or incomplete, then we can take some of the products of conception and send it to genetics. Um, and that can answer some of the question, of course, if there's any genetic issues. Um, and then if we're looking when not in pregnancy, then we can do an assessment for APLS. We can check antibodies. Um, that's going to be anticardiolipin and lupus anticoagulant. And the third one is, I'm blanking on this one. There's another one.
That beta glycoprotein.
Oh, okay, yeah, so beta glycoprotein that we need to check in two separate occasions when we have at least 12 weeks in between.
All right, is that the only thing that can cause recurrent pregnancy loss is just antiphospholipid syndrome?
No, so as I said, genetics,
Okay, and
antiphospholipid.
how would you evaluate genetics in someone who wasn't pregnant?
We can send to do carrier type. We can send for genetic counseling if we find anything to test father of the baby. Of course, we look first thing on the age of the patient, which would have a lot of significance, especially if it's at the end, the edges of the fertility period, which is very, very early, or people who are considered AMA, advanced maternal age, which is about 35, and especially people after 40. And
So we talked about, so far you've given me antiphospholipid and you've given me genetics. Anything else can cause recurrent pregnancy loss?
yes, so there can also be some structural
You want me to
abnormalities.
help you out? Yeah,
It-
structural, absolutely, absolutely. And how would
so,
you evaluate that?
so I would start with the simple ultrasound, and I can do an office hysterosonogram to see if there's with saline to see if there's any um, abnormality like septum or anything like that. Can also do a HSG to look for that.
Okay. Anything else besides structural? So then you've got antiphospholipid syndrome, you've got genetic, you have structural. What's the other one?
So I would also look at patients. I will take a very thorough history to see if there's any environmental issues like smoking, obesity, class 3, any exposure
Good.
for any toxins or anything which can, like if she has any job that expose her to any chemicals or things like that, like unusual
Good.
things.
Okay, no, that was excellent. So here's the only other thing that I'm thinking of is like endocrine issues. So like if they're diabetic or like have thyroid disease, something like that. So here's a good way to approach the questions. So, and the more you do this, the more you'll be kind of practiced at it. So if somebody asks you a broad question, such as, so what's your differential diagnosis of, recurrent pregnancy loss and how are you going to work it up?
Uh-huh.
What always is a nice way to frame it is to almost start at 30,000 feet or like almost like bullet points and then go back and fill in the details and the blanks. And what I mean by that is, number one, it helps you stay organized and it lets the examiner you see the big picture. So for instance, if another way to have answered this would have been, a differential diagnosis of recurrent pregnancy loss includes genetic, autoimmune with antiphospholipid syndrome, endocrine abnormalities, structural abnormalities, and maybe like toxin or lifestyle issues such as obesity. And then you could go back and say, what, if they asked you how would you work it up, well, with regard to antiphospholipid syndrome, I would get my antiphospholipid antibodies. If they were positive, I would have to repeat them in 12 weeks to see if it was a true positive. With regards to endocrine, I'm going to make sure they're not diabetic. I'm going to check their thyroid functions to make sure there's nothing going on there. With my structural abnormalities, I'm going to start with an ultrasound, but I can do a sonohistogram or a HSG. With regards to the other toxins, I can check to see a thorough history. Are they a smoker? Do they use illicit drugs? I will look to see if the patient's obese, etc. So do you see what I say? It's a little bit of an easier way to organize it, because when there's a lot of different things that can cause something, it's going to be really hard to remember. Now, did I already say that or didn't I say that? Because you're so nervous. So if you can almost outline it first and then go back to fill in the details, that's a good sign to the examiner that, do you know what I'm saying? That you're seeing the whole picture. All right, so let's keep going on this, because go ahead. What'd you say?
I said it sounds much better the way you said that.
Yeah, well, but that's why we're doing this, you guys, so that everybody can learn tools of how to answer an oral question, because the big difficulty is people always say, don't say too much. Just answer the question. Well, you can take that to the wrong extreme too. I was dealing with a candidate one time who said that they pounded it in his head so hard to just answer the question that he thought that they were like they'd say, okay, this patient has preterm labor or had a history of a preterm birth. Would you give her anything to try to prevent that in a next pregnancy? Yes. I mean, he wasn't saying anything more than that. And so he's like, I think they thought maybe I was being a smart aleck. And I said, well, you're not on the stand. So my point is, if you know what you're talking about, go ahead and keep talking. They'll interrupt you. I mean, if you're answering the question, go ahead and let them know your knowledge. They'll interrupt you if they don't want to hear anymore. But if you don't know what you're talking about, don't dig a hole. If that's the main thing. Okay, so let's look at this patient. So she's a G7P0 for multiple reasons. So did this patient get antenatal cervical surveillance, or was the short cervix noted when she came in with her PPROM?
No, it was diagnosed before. It was a known
Okay,
short cervix, and
okay.
yeah, she
Do you
did.
do routine cervical length surveillance on all of your patients?
Yes, I do.
Okay, so what was her cervical length, and was any intervention done?
Um, so her cervical length was below 2 centimeters.
Okay,
I
so what did you do about
quote
that?
the exact, does it matter like the exact millimeter?
But that's good. She was less than 2 centimeters. So what did you do about that?
Um, so because she did not have any history of preterm birth, she was not offered cerclage. It was close to 2 centimeters, but just below it, and she was started on progesterone.
Perfect. I don't see that on your treatment. That's why I asked that.
Hmm.
I don't see vaginal progesterone listed.
Yeah, so I should have included that. Yeah.
Yeah, so that was why I was kind of like, okay, her cervix is short, so what did you do? So yeah, if somebody's had a prior preterm delivery less than 34 weeks, and you do cervical length surveillance and her cervix is less than 2.5 centimeters, that's someone you can offer a cerclage too. But in someone who has not had a previous preterm birth, if their cervix is 2 centimeters or less, we offer vaginal progesterone, right? So just note on your case list. I don't know if you've turned your case list in already. If you have, no big deal. Just make a little note to yourself that just because you didn't put it down there doesn't mean you didn't do it. So no big deal. Okay, so then she comes in with preterm PROM. How do you make the diagnosis? Somebody comes in saying they're leaking fluid, they're 29 and 3. Tell me what you did.
Um, so first of all, history. The patient will come, as you said, and complain of either leakage of fluid or a gush of fluid that is significant. Um, and then on physical exam, I would check for pooling. I do nitrazine, and I look under the microscope for ferning. For her, she both had like clear fluid coming out of the cervix with pooling, and the nitrazine was positive, and there was ferning positive. So it was clear diagnosis of
Okay.
preterm PROM. Also, I would assess the
Okay.
fluid,
So
but
go
that
ahead.
would not be diagnostic. I mean, it would be just to give me some kind of a baseline and maybe support my diagnosis.
Yeah, and also let you know the position of the baby, right? Because
Right.
obviously, if it's breech, it's going to be a lot different management than if it's vertex. All right. So then, when you were there, did you also do her GBS culture and stuff? Is that why you put Group B strep in her antepartum column? Was she GBS
Um,
positive?
I'm trying to think why I put it here. I checked it. Like it's
Yeah,
something that I
I
do
bet you
routinely.
did. It probably. Yeah, so they come in with PPROM, you're going to do your GBS test, and you're going to put her on latency antibiotics. So then I see she received steroids, she received fetal neuroprotection, and then it looks like she was hospitalized. Mm, I guess you must have been able to finish her latency antibiotics and then she
Yeah.
started preterm labor because then you listed her prophylactic antibiotics. So there's her GBS and she had a SVD. I'm trying to think really what else. So how would you manage this patient in a subsequent pregnancy? What would you do different now that she's
Um,
had this preterm delivery?
right. So with history of preterm labor, I would start serial cervical length measurements from 16 weeks.
Okay.
And I would offer her, well, this is, it's a, there's a lot of debate about progesterone, so I'll
Would you
have,
offer her progesterone? There sure is.
yeah,
There sure is. But go ahead.
yes. So in my practice, I
Yeah.
have long conversation with them about the benefits and about the latest data that have shown that some of it has questionable benefit, but I do offer it. And for her, I would offer vaginal progesterone.
Okay. So here's another way that you guys can, especially when there's areas of controversy, and especially the progesterone's one. You know, when for a while they were saying IM progesterone doesn't do anything, don't even give it, and they were thinking of not even selling it in the United States anymore. Now they're saying, well, maybe it does something, but maybe vaginal progesterone works just as good as IM progesterone to prevent preterm delivery. Do you have a MFM at your hospital and do they kind of set policy for certain things, yes or no?
Yes, we do have an MFM, and we keep offering progesterone. Yes.
Okay, so that's what you could say. Here's what I want you, all of you guys to think of. When you've got a high risk pregnancy, especially if you practice in a hospital where where you have MFMs, I think it's very reasonable to acknowledge that this is an area of controversy. I discuss it with my patients, but the MFMs at our hospital currently still recommend that we give we offer IM progesterone for our patients with a previous preterm birth or something like that. And I'm not saying you're throwing the MFM under the bus, but you're saying you're aware of some of the different things. This is what your MFM say to do. All right, and
Okay.
that can kind of help you through some of the sticky stuff. Well, I'm going to stop here and let somebody else have a chance, but do you have any questions about kind of how we were doing and what we were going over?
Yes, I have a question. I felt like I don't know, I feel maybe I'm rusty or maybe it's like the first time we do that. But like you were kind of trying to pull the answers out of me. And I was wondering if
Mm-hmm.
that's the way they do it in the
Probably
exam.
not.
They-
Probably not. They will probably ask you the questions, and if you're just not giving them an answer, they might. I mean, every examiner is going to be different. Let's think about this. They're not trying to make you fail. They don't
Mhm.
want you guys to fail. What they want to do is identify the people who are a danger to patients and are practicing bad medicine. Does that kind of make sense? So
Yeah.
if they can tell you're nervous, they think you've got the information there, maybe you just need a little bit of prodding, that there's going to be people who are going to be more prodders, but every examiner is going to have a different exam style, so I don't even want to guess of what they're going to do that way. But you're right, I'm spoon feeding
Yeah.
everybody now. As we get a couple months further down the road, I'll be a little bit harder, but right now it's just about getting your feet wet, getting comfortable, and seeing how difficult it is to answer these questions verbally. And you might think I'm crazy, but I tell the candidates to do this. I tell them when we get off the phone, even when I do mock orals or something with them one-on-one, I'll say, okay, you had a real hard time with, chronic pelvic pain, this, and this. When we get off, I want you to practice answering that question again out loud. Just practice saying it. Because
Yeah.
if you said, okay, what's the differential diagnosis of chronic pelvic pain? And you practice saying it out loud a couple of times, I guarantee you when you go to the oral exam, it will be a whole lot easier. So just spend some time at home talking to yourself a lot and practice saying stuff out loud. It will make it easier. Kind of like
Okay.
practicing to give a lecture to somebody. When I give lectures, I practice a couple of times walking around in my bedroom saying it out loud, and it makes it easier when you get there. All right, thank you so much for being our first volunteer. Let me see, I know Richie has a case list. Let's see if Richie's gonna volunteer. If not, I'm gonna call on them anyway. All right, thanks, Aviv. All right, any other questions before we go to Richie? All right, Richie, I'm trying to unclick. There you go. How you
Hi,
doing?
I'm doing well. How are
How
you?
are you? Good. Are
I'm
you a
good.
general OBGYN? Yeah, are
No,
you
I'm
general
not.
OBGYN?
I do solely gynecology. I don't do any obstetrics. I haven't done obstetrics in 3 years.
Oh, I get you. So what type of GYN? Are you doing more MIGs or what are you doing?
Yeah, I'm a fellowship trained minimally invasive gyne surgeon. Yes.
Oh, okay. So what would you like to do? Do you have a particular case list that you would like to start with?
I can do either office or gyne.
All right, let's do that. Let's do an office since we're right here. All right, let me see.
I was like, I don't think is that mine?
All right,
No,
is this not your? Oh, nope, it's not
I
you.
was like, uh-oh.
You are right. Okay, I'm sorry.
I don't remember
So let
doing
me,
ovulation induction on anyone.
you're like, oh my God, what case list did I submit? All right, so let's do this.
Yes,
All
ma'am.
right, this one looks a little bit more familiar, right? All right, let me see here. All right, let's just look at patient number 6, and let's just do it our infertility. So you had a 36-year-old G0P0 come into you with request for a complaint of infertility. So how do you define infertility in a 36-year-old? Oops, Richie. Let's see, you're self-muted again. I can't hear you. Richie?
Hello?
Oh,
Yes, can you hear me?
Richie?
Yes,
Yeah, are
can
you
you hear
there?
me?
Okay. Yeah, we're having trouble with my audio must be. Yep, I can hear you. Can you hear me?
Oh, okay. Yeah, I couldn't hear
Richie?
you for a while. Can you hear me?
Okay. I can hear you. Can you hear
Okay.
me? Can you
Yes.
hear me?
Yes.
Okay. All right, good. Okay, good. All right, so how do you define infertility in a 36-year-old?
I define infertility in a 36-year-old as inability to conceive uh, while actively trying for 6 months.
Okay, so when she comes in, tell me with what's is significant. Well, let's just start with the basics. So how are you going to counsel her about how you're going to evaluate female causes of infertility?
I counsel her that I would take a detailed history, perform a physical exam, and possibly consider obtaining additional testing, including ultrasonography or lab work.
Okay, so in this case, was she having regular menses?
Let me see. Primary infertility. Yes, she was having regular menses.
How would you document if she was ovulating or not?
You could ask the patient if she has regular menses, or you can have her do urine LH test strips. You can
Okay,
also
and if
do,
that, go
I don't
ahead.
know. Oh, no, go ahead. Sorry.
No. Well, if she did a urine LH test and it came back positive, what would you tell her when she ovulates?
What would you, what do you mean? What would you tell her when
Okay,
she,
so
like,
so what does that the urine
hello?
test actually tell us? Does it tell us that she ovulated already?
No, it tells us that she had a spike in her
What's
LH
it measuring?
hormone. It tells her that she has a spike in her LH hormone,
Correct.
and
So
1 to 3 days after the spike, she should anticipate ovulation.
perfect. Okay, good. Yeah, and it's usually within about anywhere from 12 to 36 hours. So you're right. It's measuring
Uh-huh.
the LH surge. What else? Is there any blood test that you could do that could document ovulation?
Any other blood test? You could do I'm not sure. You could probably do a day 3 FSH LH.
What would that actually be telling you?
I don't know.
So a day 3 FSH LH is in the, yeah. So, okay. So how about a
You could
progesterone
do a
level like a
progesterone,
day
yeah,
21
challenge.
progesterone level? Yeah,
Yes.
because yeah, no, not even a challenge, not a progesterone challenge. You're just going to get a
Uh-huh.
blood test looking for progesterone because you
Uh-huh.
only make progesterone if you ovulate, right?
Yes.
So if you do a day 21 of the cycle progesterone level and it's greater than 3 nanograms per milliliter, that tells you she ovulated.
Okay.
Does that make sense?
Yes.
Okay, so let's say, so now she's having regular menses. We've proven that she's ovulated. What's worrisome about this history? What are you worried about for other causes of infertility?
Her uterine myoma.
Correct. And what about with that history of a myomectomy? What can myomectomies cause increased risk of?
Myomectomies can increase risk of intrauterine adhesions
Yep.
and can be a cause for structural abnormalities that lead to either difficulty with implantation or recurrent pregnancy loss.
Yep, absolutely. You there?
Yes, can you hear me?
Okay, perfect. All right, so you did, yep, I can hear you. So you did the ultrasound that showed multiple myomas. Tell me what ovarian reserve testing you did.
I checked an anti-Mullerian hormone level.
Okay, and what's abnormal?
Less than 2.
All right, so what is that? I thought it was less than 1, but maybe less than 2 is what they say. All right,
I think it's
so
I think it's dependent on the age as well.
okay, so age and less than 2 at 36 was considered abnormal. So what about, does that mean she's infertile?
No, it does not mean she's
If she has an
infertile.
abnormal AMH, what is that really telling us?
It tells us the success of ovulation induction with if she decides to pursue artificial reproductive technology.
Correct, absolutely correct. So doesn't mean she can't get pregnant. It just means that we're seeing depletion of those antral follicles. Okay, so then
Mm-hmm.
what was that enough for you just to send her to REI then with that and not even bother doing like a hysterosalpingogram?
So when this patient saw me for a consultation, she was requesting a repeat myomectomy, but with her abnormal ovarian reserve testing, I recommended she have further testing and evaluation with REI before considering a surgical intervention to remove myoma again.
Perfect. That makes total sense. Yeah. So normally,
Yeah.
if somebody comes in with primary infertility, if you didn't have the myomas, tell me what sort of what would you tell her would be a standard infertility workup?
The standard infertility workup would involve the patient and her partner. So I would ask the patient about ovulation in the sense of asking if are her menses regular, has she tried urine LH test strips at home, does she have a history of PID or any type of tubal surgery. That would also involve asking her if her partner has ever had a child in another relationship or has had a semen analysis.
Okay. And so then let's say her menses were slightly irregular. Tell me what labs you're going to get.
If her menses were irregular, I would get a TSH or thyroid testing and prolactin.
Okay. Would you get an FSH on her? Why or why not?
Would I get an FSH on her? I'm not sure.
Okay, so if she had like oligomenorrhea where she was going months without a menses, I would
Mm-hmm. Oh, okay, yeah.
get a TSH, a prolactin, and a FSH just to rule out
Mm-hmm.
premature ovarian insufficiency or something like that. Let's say you did her lab work, everything was fine, she's ovulating, the semen analysis is normal. Now, what's the one missing piece you still got to figure out?
For this
Labs are
patient,
normal. Go ahead.
For this patient, I would want to confirm that were no abnormalities intrauterine, and that her fallopian tubes were patent. Hello?
Okay, now I'm not hearing you again. Oh my God.
Oh, can you hear me now?
There. Can you hear me?
Yes.
Yeah, why does this keep cutting out? It's so,
I don't know.
I don't know. It's aggravating. But anyway, so then you would confirm tubal intrauterine, that structurally is normal, and that tubal patency, correct?
Yes.
When in the cycle are we
Yes.
supposed to do it? HSG and Y?
I believe you're supposed to do an I believe you're supposed to do an HSG 10 days after the first day of your last menstrual period. I'm not sure. I don't remember.
Yeah. So here, let's think about it. We don't want her to have already ovulated, right? Because we don't want to irradiate a new little pregnancy. So you want it after their menses is done, but before they ovulate. So it's not even so much a matter of a day, but if you just think about why you're doing it, that's why we're doing it then. If this patient, everything was normal, except she just wasn't ovulating. In your practice, do you do ovulation induction, or is that something that you refer to REI?
In my practice, I do not do ovulation induction. I do refer them to REI.
Okay, and so you guys, that is totally, when they're asking you a lot of things, they want to know, tell me how you practice. That's what they want to know. Like some of the candidates are practice in rural hospitals, they don't even offer VBACs at all. Okay, so they're going to have 0 on their case list. So when they get all worried, I go, just tell the examiner, this is where I practice. This is the policy of the hospital. We're not allowed to offer Tolax to our patient. And then you just have to say, but regardless, I counsel them about the benefits of the Tolac, and if they strongly desire one, I can offer to refer them to an institution that allows it. So in this case, you can say, when I see patients for an infertility evaluation, I will start the basic workup. These are the things I do, but should they need ovulation induction, the policy, or at my practice, we refer that to the REI for ovulation induction. And that's fine. That's how you practice. Does that make sense? Okay, so good.
Yes, it does.
Let's say, let's say she was, let's say this patient was not PCOS, but she just needed ovulation induction. What do you think the REI is going to give her to
This
induce
patient
ovulation?
You said if this patient was not PCOS, what would the REIs offer her for ovulation induction? First line would be letrozole.
Okay, so for sure with PCOS, first line is letrozole. I think when it comes to non-PCOS and ovulation, there's still, I don't mean to say controversy, but you can probably go clomiphene or letrozole, even though I think we're slowly switching over to letrozole for all ovulation induction. But for sure, if they're PCOS, letrozole is the preferred agent. So good. All right, so anything else that you can think of? I'm
ASR saying that
for all patients now.
Hello?
I'm here, Richie. I'm here. Can you hear me?
I think so. I'd have to I'd have to look at it again.
But you're thinking that it said for everybody now do letrozole? Okay, well, I'll double check that too. So if that's the case, then that makes sense, and that you taught me something today. Good. I guess that, do you have any other questions for me? Hello? Oh my gosh, do you have any questions for me? Richie, I can't hear you at all now. Richie.
Hello? Can you guys hear me? All right, let me go back to, all right, I'm gonna take Aviv's down. Okay, Richie, you're still,
Yes.
there you go.
Yes, can you hear me?
Yep, I can hear you. I don't know
Okay.
what is going, can you? I'm talking on my speaker phone on my computer. Am I really garbled?
No, you sound fine. You sound a little bit far away.
All right, now my headphones are working again.
Okay, perfect.
Do you have any other questions?
No, that was it. I'm sorry about the disconnections.
I don't know where everything it keeps coming up on my webinar saying you may be experiencing degraded audio quality. Please close any unused internet applications. Well, they're all closed, so I don't know why the website is having an issue. All right, good. All right, so let me see if anybody else wants to volunteer. Thank you, Richie, I appreciate it. Okay, any other volunteers? I'm just gonna check in with Ebony. Hey, Ebony, don't worry, I'm not going to call on you, but I just want to check in on you. You're muted on your end. There you go. So, Ebony, are you general GYN, OBGYN?
General OBGYN.
Hello? Okay, good. All right, and so you haven't turned in
in.
your case list yet, so that's fine. I'm not going to do anything. Huh?
You keep cutting in and out, so I missed what you just said. I'm sorry.
I said, so you have not turned in your case list yet, correct?
No, I'll turn it in by today.
Yeah, no problem. What I'm just saying is that, again, so I'm not going to call on you, but do you have any particular questions or anything about just this case list review? Anything that I can answer for you?
As regards to how the webinar will be organized, or just in regards
No,
to how my
just in general. Just in general. And if you don't, you're like, nope, I'm just going to listen and just keep practicing, then that's fine. I just wanted to touch base with all the attendees tonight.
I guess as I'm starting, today's like day one of me going through my list and looking at it in the sense of preparing for orals. How do you recommend, if you have a system that you recommend that we go about studying off of our list?
Yeah, no, that is an excellent question. So really, when you go through your list, then number one, you need to just look at, let's see, I'm gonna, Richie, hope you don't mind, I'm just gonna continue to pull your case up here. But let's look at her patient number 8. She had a 67-year-old with postmenopausal bleeding. So you just think about, they're going to ask you, what's your differential diagnosis for postmenopausal bleeding? How do you evaluate and work this patient up? Now, this patient had a hysterectomy, so it ended up being vulvovaginal atrophy, which is not the typical postmenopausal bleeding. So if you look at anything, when you look in the problem, think about, they're going to ask you, what was your differential diagnosis? How did you evaluate and work it up? How did you come up with that diagnosis? And like for the office, it's going to be like, did your like for here, patient 9, she had vulvovaginal atrophy. What if this patient had a contraindication to vaginal estrogen? What could you have given her instead? So look through it through eyes of, what could they ask me about this? How did you make the diagnosis? What would be other treatment options or other surgical options or other management options, those types of things. Okay, you got yourself muted again, Ebony. There, see, there you go. Does that kind of make sense?
Yeah, that makes sense.
And I think that's probably the best way to do it. The other thing too is with regards to one of the other recommendations I can give you guys for studying is ACOG has published so many in the last 2 years or so interim updates on the on OB. I mean, every time I turn around, like they just published a new one on growth restriction. And I'm like, so what's new with that? And of course, this was just published last month. And what's new is, in addition to estimated fetal weight less than 10 percentile, they now say an abdominal circumference less than 10 percentile is considered fetal growth restriction. The other changes that they made is for when to deliver the babies with growth restriction, and now they're really categorizing it by percentile of IUGR. So like the third percentile, they're looking at that a whole lot more serious than a baby that's at 10th percentile. So what my recommendation would be to go through those interim updates and figure out what's new. Like genital herpes in pregnancy. I'm like, why are they publishing something new there? The whole thing they're talking about is make sure that you're on adequate dosing of valacyclovir or acyclovir, because those antivirals are cleared through the kidneys, and we know pregnant women have increased creatinine clearance. So that would be a big recommendation with regards to that, of updating with that. All right.
Okay.
Those are my pearls for the day. So I'm just going to check in with Janelle and see if she has anything. Any other questions? All right. Janelle, you're muted on your end. There you go. Hey, Janelle.
Oh, hi, how
How
are you?
I'm fine. Are you general OBGYN?
Yes, I am.
Okay, good. Any questions at all for with tonight? Well, anything that
No, I don't have any particular questions
you want to
tonight.
touch base with, or you pretty much?
Yes, I don't have
Excuse
any
me?
questions. I don't have any particular questions tonight. I'm
Okay.
just kind of listening.
Okay, sounds good. All right, I'm going to go back to one more time, and maybe we can do one more quick question before we call it a night. Thanks, Janelle. Hey, Aviv, I'm trying to call you. You're muted on your end.
Hi.
There you go. Hey, how are you? Let's look real quick at something else. So we did your OB. Let's look at a quick GYN. What do you mean this doesn't look like it? You can show me? I'm telling you what, do I have like the bad voodoo or something tonight? So there's that. There it is right there. Okay, so let me just quick peek through here and find something. Okay, let's look at patient 11. So this is a patient who presented, she's 25G0P0. She presented with pelvic pain, and you obviously did an ultrasound that must have revealed 2 complex adnexal masses that were consistent with mature cystic teratomas. There was an 8 centimeter and a 3 centimeter one. Tell me about your laparoscopic cystectomy. When you're doing the cystectomy, if you go ahead. Hello?
You mean the planning of
You
the
lose me
surgery?
again? Okay.
Can you hear
No,
me?
so go ahead. When you're doing the cystectomies, if you actually punctured the cyst and had spillage of the contents into the peritoneal cavity, why is that a problem, and how would you manage that?
So with mature teratomas, it can cause, like, once the fluid gets spilled, it can cause peritonitis later on. So it's important to suction the content of the cyst and to do washings, just like to irrigate the pelvic in order not to keep any fluid. I mean, at least try to minimize it to avoid peritonitis later on.
Okay, what do on ultrasound, oftentimes the radiologist can say these findings are consistent with the cystic teratoma. What do they actually see on ultrasound?
So they would see a mix of echogenic structure in the cyst, for the most part, And there is a specific finding called something tubercle. I'm trying to think. But in general, there would be a mix of hypoechoic and hyperechoic structures of the cyst.
Yep. And sometimes you go ahead.
Yeah, and
is there any time you could go ahead?
Yeah, I meant it will just signify the different tissues that we can find in mature teratomas that can be hairs, bones like teeth, or and the gelatinic fluid that it can.
Yeah, so you're absolutely right. It's a complex cyst, but one of the things that they oftentimes see, that hyperechoic area is like that fat in the sebum in it. You can see calcifications, and then you can see some hypoechoic areas like where there's hair and stuff like that. Is there any time that you could just, what if you had an incidentally found 3-centimeter teratoma on one side? Can you observe that, or does that need to be removed?
So mature teratomas are usually benign. I usually, if of course, if it's an incidental finding, if that's because of pain, then it's a different discussion. But if we're talking about incidental finding, then I usually follow it after 2 to 3 months to see if there's any change. And again, that's is after I have a discussion with the patient, and depends on their level of comfort. Some people will be very stressed about it and want to move it immediately, and some people will just want to avoid surgery. So it's really up to who is the patient that I'm standing in front of.
Perfect. So here's where there is a practice bulletin, an ACOG practice bulletin that discusses the differential diagnosis and the management of adnexal masses. I'd strongly recommend you guys really familiarize yourself with that, because that's going to be a big, well, let's say an area of high yield in both your GYN case list and your office case list. And it talks about differential diagnosis of adnexal masses in postmenopausal and pregnant women, in menstruating women, as well as our premenarchal girls. Talks about what sort of findings on ultrasound would be suspicious for malignancy. What type of complex masses can you follow? What type of, when you can follow a simple cyst, when you should get tumor markers, when you should refer to GYN oncology. So that would be a very high yield thing. You're absolutely right. What we worry about with the spillage of the teratoma contents is a chemical peritonitis. What that does is it sets up inflammation, and it can cause just severe pelvic adhesion. So you're going to suction the material up, do copious irrigation, etc. Other things they could maybe ask, maybe what percentage of teratomas are bilateral? It's about 10 to 15%. The point being, anytime you go to do a cystectomy, look very closely at the other ovary. And you did a great job. You saved the ovaries, yay, of a 25-year-old. So good. Any questions?
No, not on, no.
Okay, all right, sounds good. All right, so we're right at 9:30. I'm actually doing tomorrow's webinar. I pray to gosh that I'm going to actually try a different headset and see if maybe it's maybe it's the GoToMeeting webinar site. I don't know why it is, but I apologize for the in and out audio. But tomorrow will be structured cases where I'll actually present cases, and we'll go from there. All right, you guys, thanks so much for participating.